Is there? I bet you know about this issue about Medicaid shutting off when people go into a jail or a prison because constitutionally you have a right to health care. Funnily enough, the only people with constitutional right to health care are people behind bars, and so the facility is supposed to pay for that. And there's always been problems with people. They have the Medicaid, then they're off it, and then they come out. Getting them back on is impossible. Has any progress been made on that?
Well, that's the kind of thing that in some places they've made good progress, and in some places they've made horrible progress. One of the basic issues is to make sure that when guys leave a secure facility, and there's jails and prisons, and there's different issues in those. A lot of guys go into a jail for a short period of time, and they come right back into the community. And a lot of mentally ill people who are committing sort of minor crimes, that's exactly where they're going to cycle through. And if you basically disconnect them from services, put them in the jail, and then when they leave, kind of expect them to show up at some agency with their nice little shoebox with their forms nicely arrayed so that they can sort of pass all the paperwork requirements, it's just not going to happen. And we actually know that there's an incredibly high mortality risk in the 2 weeks after people are released from criminal justice settings, and sometimes they just overdose is one of the major ones. You just go back to the same place where you bought heroin, and you buy heroin again, only now you've been detoxed in the jail. So you overdose when you took the same dose that you took before. Or you show up at the same place where you were selling drugs before, and there's a new guy standing there who's selling drugs in your absence, and then something bad might happen to one of you.
Yeah.
So it's really important to make those sort of the boring blocking and tackling of doing this right matters a lot. And so I think that progress is being made, but it's really, I think right now there's a real question of just making sure that in every state capital that they're really on this. At least every state capital that does the Medicaid expansion. Obviously one of the challenges that we have is that not every state wants to expand Medicaid. And the states, as we're waiting, states like Texas that are not going to expand, obviously, they have even worse problems now on account of that.
Yeah, I like that expression, the boring blocking and tackling. As it's exciting to work on federal policy and X million people getting insurance and all that, but then it actually depends on, an overworked discharge clerk at a county jail to make sure that person gets their Medicaid back. And a lot of really, just dull as dishwater problems of overstretched bureaucracies. And you have to help those systems learn oftentimes just what they need to learn is just one smart thing. That's the most they can do. They can't handle a treatment manual with 900 pages, but you teach them just do this one thing for people. And that's a challenge. I think that's a challenge to people like us who tend to work at a more conceptual policy level. Not to say that isn't valuable, but also just think about how do we make these things real on the ground, and the hard work of that is really enormous.
Yeah, I like to think big thoughts, but the actual implementation is, we often leave that to other people to worry about.
Mm-hmm.
Now, what are some of the challenges you think we're going to face in really making health reform work for mental health and substance use
Yeah.
in that arena?
Well, both, one of the really, striking things I saw when I was in Washington is a lot of advocates go home after the law is passed. We've won, and they go back. But there's a whole bunch of people who stay, and they're the lobbyists. And a lot of them, were against those very same laws, and then it goes into the regulatory process. And they're there working on that all the time. So parity, passed in 2008. It took the Obama administration a long time to get interim regulations out. There's tremendous fighting from the industry on that. There'll be tremendous fighting from healthcare insurers, about many aspects of the ACA. Those governors are fighting the Medicaid expansion. So you think, all right, so the black letter law may not be realized unless the regulations are right. And then even then, you often need legal action to get them to be real. So, somewhere in this country this coming week, someone's going to, have their kid have a schizophrenic break and go to their employer, to the benefits department, and hear, no, we don't cover that schizophrenia, and their rights are being violated, but they may not know it, or they may have to sue to make the law real. We've seen this with everything. Civil rights legislation, housing legislation have to fight, and that's a long battle that takes years to win. Particularly because this population is still stigmatized, and a lot of people, there's a lot of people who go on television to talk about their child's battle with cancer and how they got beaten up by a health insurer or a hospital. There's a much smaller number of people who would be willing to go on television and talk about their child's struggle with drug addiction or schizophrenia or some other condition that scares the hell out of people, is stigmatized, and those parents know half the people listening to them will blame that parent for the problem in the first place. That's part of the hell of having.
And also, of course, you're going through a really difficult personal experience, and your ability and desire to be a political advocate is limited by the fact that you're busy in the trenches trying to help your kid with this problem.
You bet. You're at your weakest, and you've got a lot more enemies than friends, I think, in those situations.
Now, another thing that concerns me is the capacity of the existing system of treatment to really deal with Medicaid. I think that there's two things we haven't emphasized in this conversation yet, but that are important. And one is that Medicaid is going to become the dominant payer for a lot of these services. And right now, these services are paid for in other ways. And there's a real question, how many providers are actually ready to work with Medicaid? Do they have a computer system that can send a bill to Medicaid? Do they have a doctor on site who can sign the appropriate forms that you need to satisfy all the Medicaid requirements? So, there's a lot that is very rinky-dink about the existing substance abuse treatment system, and it's not the fault of the providers. This is at the level of funding and so on that we've provided. An ecosystem has grown up, which is not really sophisticated in terms of what we expect, what Medicaid's expected. And so some of these places provide excellent care, but they have to figure out how to tool up to get money from Medicaid. Some of these places don't provide excellent care, and probably they should go out of business, but that's going to be a very painful process.
Yeah, and what you're saying applies equally well to the new, the expanded Medicare benefit and these, private insurance plans through health exchanges. I don't know the number. I wouldn't be surprised if half of substance use treatment agencies in the U.S. basically know how to report their workload to the block grant, which is the federal set aside for them, and really don't know how to interface with any other payment system. And I think those places will go out of business eventually.
Now, one thing about that will be painful, but there's actually a positive side of that, in that for the first time, for many substance users, they'll have a real choice, and they can use their regular doctor or go to the health system that takes care of their physical health needs will have a big incentive to start taking care of some of their other needs. And they may say, hey, I've been going to this methadone treatment clinic for a long time. They've been giving me a pretty undignified service, and I had to come because I had no choice. Now I have a choice. I'm going to go someplace else. That's actually a good thing.
Yeah, absolutely. It's just, in other words, they'd be given the choice virtually anyone else with a disease would have if they had good benefits. So another question too is, what are these programs, these sort of the programs that have lived on the block grant going to do? And another possibility is they could do something different. So I'd be in favor, for example, of retooling the block grant a bit to focus on recovery support services. So you think it less as the acute health care, but you could still fund people to do recovery coaching or help people set up housing or all the long-term stuff people tend to need, because particularly in the public sector, very few people have low-level substance use problems that will go away if you give them a really good brief intervention. There are patients like that, but you don't see them mostly in the public sector. So they could retool what they did. That when I was, when I worked in the White House Drug Policy Office with my friend Tom McCullen, and we were working on this stuff, we are both treatment guys, so we had a lot of people from the treatment field coming to us saying basically, okay, your job is to get us more resources to do what we always do. And what we said back was, actually, that's not our job. Our job is to try to craft policies that will, do a better job of helping this population of people. And that will create opportunities. And we hope you'll take advantage of them. But it's not our job to preserve the system exactly as it is. And it may be new entrants will come in and find a way to take advantage of the situation. And if so, that's a good thing, not a bad thing.